At the outset, I'd like to thank the organizers of Lipidicon for having invited me to this lovely location and at a great time of the year when we're having our first rains. And this interesting topic coming as a culmination towards the end of the meeting really is given to me to make you think, how do I change this? Hello? To make you think differently. Because everybody talks about statins for its particular aspect of function. As we know it, statins and its use in lipids. We want you to think a little differently as to why statins can also be used from different points of view and how they help in the mechanism of atherosclerosis. And that is the concept of inflammation. It was Virchow who critically analyzed the meaning of the 4 key symptoms of inflammation: redness, swelling, heat, and pain. And through his pathohistological investigations, inflammation was widely accepted as a central cause of atherosclerosis. Atherosclerosis, as we know, is a fibroproliferative and inflammatory process occurring in response to a variety of vascular insults. Endothelial dysfunction is regarded as the first abnormality leading to atherosclerosis, and this implies that modulation of endothelial function, if we take up a process that modulates endothelial function, it may be used as a strategy to intervene in atherosclerosis. As we know, atherosclerosis is a leading cause of death worldwide. From AIDS, lung diseases, injuries, cancers, infectious diseases, it still overtakes all of them, and today atherothrombosis has almost a 30% incidence. In India, as we know, CV death is the largest cause of mortality in all regions of the country. So atherothrombosis is something which we really need to look at very minutely from the endothelium level. And how does this atherogenesis come about? The increased LDL in the serum leads to LDL infiltration, LDL oxidation, and this oxidation jumps from the free radical to cell proliferation, moves sideways to endothelial dysfunction, platelet aggregation, to finally down the line from foam cells, lipids to calcification. And as you can see here pictorially in the bottom line, endothelial dysfunction leads to inflammation. Inflammation then causes oxidation. This oxidation process causes plaque instability and thrombus formation. And you can see here in the picture how the different monocytes, macrophages, attack the foam cells, produced oxidized LDL cholesterol, leading to the plaque, and finally plaque instability and rupture. The inflammation goes on. It promotes atherosclerosis progression further from the vessel lumen to the endothelium. Inside, in the intima, the LDL gets oxidized further with the help of inflammatory mediators, macrophages, and adhesion molecules, then produces a continuous lining of inflammation all through the intima. And all this with the use of inflammatory markers, interleukin-5, total cholesterol, LDL cholesterol, CCAM1, serum amyloid A, apolipoprotein B, HSCRP, all this put together increase the relative risk. These are the inflammatory markers in atherosclerosis. Having known that inflammation and atherosclerosis go hand in hand, we are now treading new ground. We have realized that CRP and now HSCRP is something which we measure to find out the susceptibility of our patients to atherosclerosis. And the role of CRP in the atherosclerotic plaque formation and rupture, from opsonization to increased markers to complement activation to endothelial sensitization, finally leading to atherosclerotic plaque formation, which ruptures and causes thrombosis. CRP plays a direct role in atherothrombosis, not on the normal intima, but on the inflamed intima because of complement activation, inflammatory markers, reducing nitric oxide production, triggering oxidation of LDL, blunting of endothelial vasoreactivity, so many factors. CRP is the chief orchestrator. And all the studies have clearly shown that the higher the CRP levels, the higher the CV risk. Of course, now we look at HSCRP, which was not there at the time of Framingham. And if you look at the role of LP little a and LP LA2 molecules, how from the intima, within the surface, they produce through cytokine modulation, macrophages, monocytes, adhesive molecules, leading to plaque formation. It is leukocyte activation in atherothrombosis and atherogenesis, which produces oxidative stress, which through all the different inflammatory markers stimulates leukocyte infiltration and activation, finally producing plaque rupture. And if you look at the role of nitric oxide, hyperlipidemia, accumulation of AGEs, oxidation of LDL, increased reactant oxidant species, decreased nitric oxide, reduced eNOS expression, all leading to atherogenesis. Now, this is an important marker, IL, interleukin-1 in atherosclerosis. Interleukin-1 is an important marker and an important inflammatory cytokine. You know, there are two types of cytokines in atherosclerosis, ones that suppress and one that stimulates and promotes. And you can see the red arrow is bigger than the other green arrow. So the balance has to be well maintained. And the pro-inflammatory signals in the endothelium and the leukocyte by NF and KB drives the atherogenesis. We are always looking at answers. Today we had a lecture before this where Dr. Kapoor showed you which statin to use. But we are interested in more than anti-lipid, more than statin. And that comes from the fact that there is the inflammatory component. And if you look at the mechanism of inflammatory responses, the endothelial dysfunction, once it happens, there is an initiation. All the inflammatory markers get triggered. That itself propels progression. And through platelet adhesion and other inflammatory marker activity, produce plaque destabilization. And this foam cell plaque, which is inflamed with macrophages and oxidized LDL, finally ruptures, leading to the clinical manifestations. There is ischemic stroke, TIA, angina, MI, peripheral arterial disease. And identifying those at risk of atherosclerosis, of course, the local factors where there is elevated prothrombotic factors, blood flow patterns, vessel diameters, arterial cell wall, systemic conditions, vascular events, hypertension, hyperlipidemia, homocystinemia, lifestyle, of course, diet, smoking, lack of exercise, genetic traits, gender and age, and of course, lifestyle disorders like obesity, diabetes, all of them contribute to the atherothrombotic manifestations of MI, vascular death, and stroke. There is a close hugging relationship between dyslipidemia and inflammation because they are closely intertwined in their contribution to atherosclerosis and cardiovascular risk. Nothing goes without the close relationship between dyslipidemia and inflammation, because lipid dysregulation triggers inflammatory and immune responses through the target cells, through the mediators, and through the effectors. The modified LDL is a strong inducer of inflammation and atherosclerosis, which is why today in the lipid profile, your first glance is to LDL. And interleukin-1 beta activation by modified LDL through TLR and NLRP3 inflammasome clearly shows that if you modify the IL-1 beta, you see interleukin-1 beta is a connection in the mechanism of action of LDL lowering therapy and this canakinumab, which is the anti-inflammatory molecule, where they showed that IL-1 beta synthesis may be inhibited by LDL lowering therapies, while canakinumab binds to IL-1 beta, inhibiting its effects. There was the study called the CANTOS study, and the impact of the CANTOS study on the understanding of interplay between lipids and inflammation. What were the results of this CANTOS study? Targeting inflammation can be effective in the therapy of atherosclerosis, and the first proof of principle about the link between lipids and inflammation was from the CANTOS study. Canakinumab did not decrease lipid levels, while it slightly increased TG levels. Thus, the CANTOS data excludes the possibility that the canakinumab reduces CV risk through lipid-dependent mechanisms linked to IL-1 beta. It is not the lipid-dependent mechanism, but it is the anti-inflammatory mechanism. So the moment of truth is very clear. It is inflammation and inflammation alone. 20 years ago, when we were just looking at all the risk factors, CRP was not even being considered. Today, hsCRP is an important parameter and marker in the prediction. So are there anti-inflammatory effects of statins which we can reap and milk for the benefit of our patients? The cytokine-based approaches in atherosclerosis, where statins, aspirin, methotrexate, colchicine, everything has been tried in the lumen to look what happens in the vessel wall. And the cytokine-related statin effects in atherosclerosis have been clearly demonstrated from the lumen into the vessel wall. A clinical evaluation of statin pleiotherapy and pleiotropy was seen where statins selectively and dose-dependently reduced vascular inflammation. And the anti-inflammatory potency of increasing doses was evaluated in 60 patients over 3 weeks on statin therapy. And it was seen that statin treatment reduced all the inflammatory marker levels. It reduced NF-κB activity with statins, and this brought about a justification to do a study called the Jupiter study. Justification for the use of statins in primary prevention. It is an intervention trial evaluating rosuvastatin. This is interesting. They chose patients in the prevention of cardiovascular events with individuals with low LDL, where you did not need to give rosuvastatin, but elevated hsCRP. Rosuvastatin 20 in patients with no prior CVD or DM, men or women, women over 60, men over 50, LDL under 130, hsCRP more than 2. What happened? This was the vulnerable population that they were looking at, moderate and high risk. Look at the baseline levels. Patients who were given Rosuva as well as placebo had LDLs of 108, but HDLs also similar, but they had very high hsCRP, 4.2 and 4.3. And the effect of rosuvastatin was very clear. Over and above dropping the LDL, they also dropped the hsCRP. Thus, the reduction in MI, stroke, revascularization, CV death, all was reduced by a whopping 44%. So 20 milligrams of rosuvastatin as compared to the placebo dropped by 44% the reduction. And if you compared the event rates in those achieving LDL less than 50 versus those more than 50, it also goes in favor of rosuvastatin. A study then was conducted to evaluate the effect of rosuva on vascular ultrasound-derived coronary atheroma burden. That's the asteroid study. And there was very significant reduction. You know, IVUS, intravascular ultrasound, which looks at the coronary atheroma, and that was shown to be significantly reduced with rosuvastatin. They went further and they measured the effects on the intima media thickness and evaluation of rosuvastatin in the METEOR study. So the question in coronary artery disease always raises treatment queries, and the treatment queries are well answered with the help of all these studies. The METEOR study also gave rosuvastatin 40 versus placebo, and the primary endpoint was to see the change in carotid intima media thickness. And rosuvastatin significantly slowed the progression of carotid atherosclerosis very significantly, indicating that the atheroma burden was being suppressed. We have so many other studies, ASCVD, where atorvastatin reduces plasma inflammation. We have atorvastatin effects on inflammatory cytokines in type 2 diabetes in the PANDA study. Results from the protection against nephropathy in diabetes with atorva. It's a randomized trial where they showed better control of lipid and inflammatory markers with high-dose atorvastatin. Then there was the SHARP study, the results of the study of heart and renal protection. And the eligibility of these patients was a history of chronic renal disease, not on dialysis, men and women, and on dialysis, hemo or peritoneal. And they compared this in patients, and they saw that when they had major atherosclerotic events, did they receive statins or ezetimibe or placebo? And they showed a 17% reduction in CAD deaths, MI, non-hemorrhagic strokes, and revascularization when they're given anti-lipid therapy. So the major atherosclerotic events by renal status at randomization was also in favor of statins. Everybody knows the pravastatin Voskhorst trial, where the prevention of coronary heart disease was looked at. Then again, the Prove It and the TIMI study, where they used not only anti-inflammatory, but they gave anti-infective line of treatment. More than 4,000 patients, acute coronary syndrome, given standard therapy, intensive therapy, in addition given an anti-infective line, 2-year follow-up, and that too showed reduced CV event with high-dose statins. So, if you look at the infancy of our knowledge, statins began as an anti-lipid drug alone, and they all said it helped in reducing LDL. But it's mind over matter when we think and realize that atherosclerosis is a major cause of increased cardiovascular events. Cytokines drive inflammation, and that is the major culprit in atherosclerosis. Statins remain the mainstay for counteracting lipid abnormalities. Better cardiovascular risk reduction with statins is well proven, but it is the anti-inflammatory action of statins, which is well elucidated in various landmark clinical trials. That is the knowledge that we need to glean and that we need to give. And if you remember in the session before this, we were discussing that in the standard of care, you really got to look into this. So, if you look at this, what's important that you now know what lies beneath. You also know what we have adequate data on, and this will plant hope to people to use statins a little more boldly. Thank you for your attention.
Thank you, Hemant, for a lovely presentation.